Welcome to the Tibialis posterior tendon dysfunction lecture. Credit needs to be given to Dr. Carl Landolf, who put this lecture together, and I, Daniel Bonanno, have subsequently updated it over the last few years. This is an interesting condition that is one that will be seen clinically, and I think it's important for podiatrists to be able to recognise this condition, as it is known to be a progressive condition and can be quite disabling for people who suffer with this condition. The good news is, if it's detected, diagnosed and treated early, the progression of the disease, tibialis posterior tendon dysfunction, can be halted and people's mobility can be maintained. Students should be able to discuss the clinical features of tibialis posterior tendon dysfunction. They should also be able to describe the anatomy that's associated with this condition. Students should be able to identify the etiology and the contributing factors of tibialis posterior tendon dysfunction. And what we mean by that is to be able to know what sort of conditions are often associated with this disease process. Students should also be able to explain the different clinical signs and symptoms associated with this condition based on the various stage of dysfunction in which their client is presenting. And importantly, everyone should be able to discuss the different treatment options that exist for tibialis posterior tendon dysfunction. So an outline of this lecture will start with a general introduction. We'll review some of the anatomy that's involved with this condition. We'll briefly touch on the etiology. A very important step will be to discuss the different stages of dysfunction. Then we'll talk about how we can come to a diagnosis, and again, something that our clients will be keen for us to be very good at will be how to treat them. So the disease process, or the condition known as tibialis posterior tendon dysfunction, is characterised by several key traits, each of which will vary in severity depending on the stage. However, regardless of the severity, most of these traits are present. The first one is the tibialis posterior mechanism is weakened, and this then results in a loss of control of the foot. And what we mean by that is basically the foot becomes flatter in appearance, and a pes plano valgus deformity occurs. And I think the important point on this slide is the fact that it's an acquired flat foot. So the foot actually may not be flat to start with. It may, but it may not, and it gets flatter over time. This condition is typically quite painful and disabling and can affect people's day-to-day function in terms of affecting the mobility substantially. The condition tibialis posterior tendon dysfunction is also known as several other terms. It's known as tibialis posterior dysfunction. However, locally in Australia we prefer to call it tibialis posterior tendon dysfunction, as it's a bit more specific in regards to identifying that there's a tendon involved. In the United States of America, they tend to use the term posterior tibial tendon dysfunction. The reason why we are choosing to stick with the term tibialis posterior tendon is the tibialis anterior tendon is always referred to that, tibialis anterior, and for consistency reasons we refer to the tibialis posterior tendon dysfunction in a similar way. As it is an acquired flat foot and occurs among adults and not children typically, it can be known as adult acquired flat foot or also the progressive flat foot. Either way, all of these terms are quite descriptive of the condition. It's progressive as it develops over time, it's acquired, it's not congenital, and it typically affects adults, and it always involves the tibialis posterior tendon. It's good to be familiar with the anatomy involved with this disease process, and you may recall from your previous anatomy lectures that the tibialis posterior originates at the lateral, posterior and proximal shaft of tibia, as you can see on this image, and it also attaches on the medial posterior and proximal aspect of the fibula. In between these two bones there's the interosseous membrane, where the tibialis posterior also originates from. As it moves distally towards the foot, it passes through the tarsal tunnel, and it will pass deep to the flexor retinaculum. It then continues distally, where it inserts onto several structures. It mainly inserts onto the navicular tuberosity and metatarsals 2, 3 and 4, but it also has some tendon slips that will attach onto the cuboid. Some attachments also occur with the cuneiforms. But the main area of attachment are metatarsals 2, 3 and 4, and that's base of those metatarsals, and the navicular tuberosity. The action of the tibialis posterior is several. It does assist with plantar flexion of the ankle, however this is not its primary action, and it's relatively weak plantar flexor, as the gastrocnemius and soleus are our main ankle plantar flexors. Its main role is to create supination of the subtalar joint, or more specifically in gait, it's to actually resist pronation. So when it supinates the foot, that's a concentric contraction of the tibialis posterior, whereas when it's resisting pronation, it's undergoing an eccentric contraction. It's actually lengthening whilst performing that contraction, and it's decelerating foot pronation at the subtalar joint. It also adducts the forefoot, which is an important action to consider, because as this muscle becomes dysfunctional, we note that the forefoot tends to head into an abducted position. It also plays an important role in regards to providing midfoot and forefoot stability. When we consider the action of the tibialis posterior during gait, I guess its main function is its antepronator action, and this typically occurs in the early stages of gait, mainly from heel strike to mid stance, as it attempts to decelerate foot pronation. Tibialis posterior tendon dysfunction can be caused by, I guess, a number of events, and these often get broken down into different types of tibialis posterior tendon dysfunction. Type 1 normally relates to some direct trauma that may have occurred to the tendon. This could easily take place in a car accident, a severe ankle sprain, industrial incident, etc., etc. So it's direct injury, and apart from that, there may be no other etiological factors present. Type 2 is where the rupture takes place and it's secondary to another disease process, and rheumatoid arthritis is one that's often associated with this type 2 cause of tibialis posterior tendon dysfunction. Type 3 is where the tendon ruptures of unknown cause, and this is known as an idiopathic rupture. And type 4 is a functional rupture. This is where the tendon is actually still functioning, but it's functioning poorly. So it's not totally ruptured, it's partially torn. However, some of the tendon fibres are still intact and is still able to perform to a degree. Other contributing factors to the development of tib post tendon dysfunction include hypertension, obesity, diabetes mellitus, previous surgery or trauma to the medial aspect of the foot or ankle, steroid exposure, and also rheumatoid arthritis. Although these conditions or situations can't be seen as a cause, they're more commonly observed in people with tibialis posterior tendon dysfunction than populations without. A major reason why it's thought that this tendon tends to become dysfunctional is that it has very poor vascularity as it passes behind the medial malleolus, and this is known as a zone of hypovascularity. It tends to correspond to where the tendon mainly ruptures, and it's thought to relate to the anatomical course of the tendon as it passes behind the malleolus. And when you consider its anatomical course, it's quite a sharp turn behind that bony prominence. Some have suggested that when the foot pronates, the tensile forces increase through the tendon, and we're referring to pronation of the subtalar joint and midfoot region. It's also thought that as the foot pronates, the gliding resistance between the tendon and the bony surface is increased, and that this could therefore increase those tensile forces and eventually lead to tendon rupture and breakdown. It's important to recognise that the tibialis posterior tendon is actually quite vascular at its osseous insertion, and it's actually rarely seen to rupture there. So it's often at this point of hypovascularity where we see trauma, and as a result of the hypovascularity, it tends to be quite a slow healer. Earlier we mentioned that some of the features of this condition will depend on the stage of dysfunction, and therefore it gets broken down into 3 stages. We have stage 1, where the tendon is dysfunctional, however its length is normal. As the disease progresses, it moves into stage 2, where the tendon becomes lengthened and the hindfoot tends to become more mobile. In 3, the tendon is further elongated and the hindfoot becomes quite deformed and stiff. And when we say deformed, it falls into a everted position and becomes quite pronated. Previously, there used to be a group known as the Tibialis posterior tendon dysfunction group, and that was anyone who had a pronated foot. But this has been removed, as many people have pronated feet and never develop any pathology. There seems to be quite a strong link between the tendon pathology, what's seen clinically, and radiographic changes that are seen. So there seems to be a bit of an association that as the tendon progresses and deteriorates and becomes more dysfunctional and elongated, the foot becomes more painful, symptoms increase, and this is often shown up with radiographs as well. So I want to focus on some of these stages in more detail. So as mentioned on the previous slide, with stage 1, the tendon length is normal. If you were to use an ultrasound or MRI, it would show that there's some early tenosynovitis and tendon degeneration. The pain is typically mild and not very specific, so it's quite diffuse, and clients will often report some vague pain on their medial ankle, but it's not very specific. And typically this pain is exacerbated by activity. So the more that they're on their feet, the more activity that they perform, the more symptoms are experienced. Clinically, what you would typically observe is some oedema and warmth and tenderness over the tendon, particularly over its distal course. If you were to get your client to perform some functional tests, such as muscle testing, or more importantly single heel raise tests, they may demonstrate weakness and experience some pain. In stage 1, their foot alignment is typically quite normal and the foot hasn't flattened at this point. It's unlikely to have changed. If in doubt, it may be worth getting an MRI or an ultrasound, as it can be useful to demonstrate tenosynovitis. However, often the tendon will present the same as what you'd expect with any type of tendinopathy affecting the tibialis posterior tendon at this stage. In stages 2 and 3, it's quite different. An example of how to perform muscle testing is to place your hand on the medial side of the foot and get the client to invert the foot against resistance, and this is best done with an isometric contraction, as you'll be able to get the tibialis posterior tendon to contract whilst not undergoing any movement or motion at the subtalar joint or ankle. So if pain is reproduced, you can with confidence assume that the pain is coming from contractile tissue. And here's an image of someone with tibialis posterior tendon dysfunction. It looks like it has slightly subluxed or dislocated, and as you can see, it's shifting over the medial malleolus. With stage 2, the tendon becomes elongated, and this typically occurs over a period of time. It can be quite variable and occur over as little as a few months or up to several years. And the spring ligament can also be affected. And the spring ligament, for those of you who have forgotten, passes from the calcaneus to the navicular, so it actually plays quite an important role in stabilising the midfoot and the hindfoot. Pain in stage 2 actually increases and tends to become less diffuse and a bit more specific to the course of the tendon itself. So clients can now be a bit more specific with where they're feeling their pain. The weakness and fatigue that they may have experienced in stage 1 is also exacerbated and advanced, and there seems to be a more pronounced swelling, warmth and tenderness in the region as well. So effectively, a lot of the symptoms that they were experiencing in stage 1 become exacerbated in stage 2, with the greatest change being that the spring ligament is now becoming more affected, and this has led to further instability of the foot. So if we look at the tendon more specifically, here in this image we can see someone who's having surgery to their medial ankle, and you may just be able to make out that this tendon has a longitudinal split in it, and it's right in the centre of the tendon. Basically that's a partial rupture of the tendon that's taking place. Clinically, some features may be a bit different with stage 2 to stage 1. With muscle testing, the muscle is so weakened that the client will be unable to invert the foot against resistance. And as the muscle has become so weakened, we start to see some structural changes occurring with the foot. And what tends to happen is the medial longitudinal arch begins to collapse or decrease in height. We see the forefoot becomes more abducted, and you may recall early on when we looked at the action of the tibialis posterior tendon, one of its actions was to abduct the forefoot. So as it's not doing this anymore, or not as effectively, the forefoot becomes abducted and the heel forms into a valgus position or an everted position. At this point, it's safe to say that the tibialis posterior tendon is behaving quite a bit differently to your straightforward tendinopathy. It's now becoming a ruptured tendon, and that's where you can definitely set them apart. Again, for diagnosis, you can undergo muscle testing to observe or document the weakness or strength of the structure, but one major clinical feature is looking at the overall foot structure, and a decrease in the height of the medial longitudinal arch will be evident. And you can see here that arch is quite flattened, it's quite pronounced on the medial side. Although you may not be able to see it all that well with this image, the forefoot becomes quite abducted. Here we can see the same person from a posterior view, and the too many toe sign has been used, and it's important to compare the 2 feet. So comparing the symptomatic foot with the contralateral foot, and comparing arch height, forefoot position, and so forth. It's important to note that the forefoot is abducted on the rear foot, and you need to consider whether the leg is just externally rotated, as this can lead to the too many toe sign being evident, whereas with true forefoot abduction, it needs to be considered in light of the position of the rear foot. So when there's some structural changes to the foot, its overall posture is changing, it is now moved into stage 2 or possibly stage 3. 2 relatively recent studies have looked at the biomechanics of the foot and ankle in participants with tibialis posterior tendon dysfunction, or in the second study you can see there tibialis posterior tenosynovitis with associated flattening of the foot, which would suggest that it is tibialis posterior tendon dysfunction. In the first study by Ness, they compared patients with this condition to controls and found that those with tib post tendon dysfunction did demonstrate increased rear foot eversion, increased forefoot dorsiflexion relative to the rear foot, which would suggest that if the forefoot is dorsiflexing on the rear foot, the arch is also lowering. Forefoot is abducted, as we have previously mentioned, and there was reduction in dorsiflexion of the hallux. In the second study, which looked at patients with rheumatoid arthritis, and ultrasound confirmed tibialis posterior tenosynovitis, and they also all had a pes planus foot alignment, it did demonstrate increased tibialis posterior muscle activity, reduced ankle power when walking, so decreased strength, which we'll probably touch on in a few later slides on when assessing people with tibialis posterior tendon dysfunction. Decreased navicular height, as we have seen in previous slides where there's lowering of the arch, and again, much like the first paper there, increased forefoot dorsiflexion relative to the rear foot. With stage 3, the tendon is markedly elongated, so it's further progressed in its lengthening, or it may be completely ruptured. Pain is still present on the medial side of the ankle, and may also now be forming on the lateral side of the foot and ankle due to the severe everted position of the rear foot. The sinus tarsi becomes impinged and compressed as the foot pronates across, and therefore that can result into some lateral subtalar joint symptoms. And in some instances, the calcaneus is so everted that it starts to abut on the base of the fibula, and this can lead to lateral pain. Here we have someone who is experiencing stage 3, and they're getting some lateral compression on their lateral foot, so the calcaneus is now butting into the base of their fibula, so lateral symptoms are quite common. With stage 3, in a clinical situation, you will note, and the client will typically report, a marked weakness of their muscle tendon unit. Also, because they've already passed through stage 2, their foot's been pronated or in a pronated position for some time, their foot becomes more fixed and stiff. And this can make treatment a bit more difficult because it's hard to then supinate a foot that has a more fixed position. And the reason why it becomes more fixed and stiff could be just through some joint stiffening, but they typically become more arthritic as well, as the joint loads and stress through that part of the foot are not considered to be normal and are considered excessive, as the tibialis posterior tendon provides a lot of stability to that region under normal circumstances. Because the foot's so pronated, on radiographs, spurring can be observed due to the amount of stress on the deltoid ligament. As it strains on the medial malleolus, osseous spurring or an exostosis can form. So these are the symptoms and the clinical features and the different stages of the condition, and much of which will lead to and assist you with the diagnosis. But let's go through that in more detail. So it's important to aid you with your diagnosis to take a thorough history, and to note that the pain is typically going to start on the medial side of the ankle or foot. The patient will then report, as they move into stages 2 and 3, that the foot has progressed and collapsed, and it's usually a unilateral change, so hence it's important to compare to the contralateral limb. The client will often report a feeling of weakness, tiredness and fatigue, and this is normally tied in with their lack of strength and weakness. When you observe the medial ankle, you'll note that there's some oedema present, the area is warm to touch and is particularly tender, and this will typically worsen as the disease advances. Further, some points that we've already covered, from a posterior view, too many toe sign will be evident. The tibialis posterior muscle will typically be weak, and a clinical test that's regularly performed is the heel raise off the ground test. Clients may have an inability to do it, or even if they can do it, what may be observed is the foot fails to invert as it normally would. Hence it's important to perform this clinical test on both sides, and again compare the symptomatic with the contralateral limb. And the overview, shape and position of the foot will have changed, particularly in stages 2 and 3. The forefoot will become more abducted, the medial longitudinal arch will lower, and the heel or rear foot will be in a more everted position. Here we have someone doing the heel raise test, and you'll note on the right foot the rear foot is inverting as it normally would, whereas on the left it remains in an everted position. Under normal circumstances, as you rise up onto your toes, the tibialis posterior tendon should contract and invert the foot. You'll also note that we're seeing some medial bulging of the foot, which is also typical with tibialis posterior tendon dysfunction, and under a normal circumstance, even with a flat foot, the arch should begin to lift up and increase in height. If you're not confident with your clinical diagnosis, it may be worth considering some radiographic investigation, and X-ray changes are typically seen in long-standing cases, and some of the clinical features that we've already discussed can be measured and documented and used as a baseline measure for future reference to note whether the condition is progressing and at what rate. Ultrasound is an excellent tool to use to image the foot, as it is relatively inexpensive and cheaper than using an MRI. However, an issue with an ultrasound is it is operator dependent, and therefore it relies on good operator skill to give you a good, clear diagnosis. MRI is an excellent choice. It demonstrates synovitis. It also can give us an indication of the degree of degeneration or rupture within the tendon. However, unlike ultrasound, it's quite expensive. However, again, it's less operator dependent. So here we have some radiographs of a person with the condition in question, and as we can see, the forefoot is abducted on the rear foot. Here we are now looking at the talar inclination angle, and that is extremely low. Typically, if you bisect the talus, it should pass through the first metatarsal head. Here we have an ultrasound of the tendon, and what you may note is there's hypoechoic signals on either side of the tendon. That's that black area, seeing a loss of fibres essentially in those blackened areas. On MRI, we're seeing in the first image, the T1 image, some normal anatomy. That's why the T1 image is important, whereas we're wanting to see some homogenesis within the tendon structure, and we can in that instance, so it's all nice and black. Whereas you'll note in the T2 image, where we can see pathology and possibly the presence of inflammation in particular, we can see a large area of increased intensity indicating inflammation. So there's two colours, there's some white in the region. Imaging can assist, and it can help diagnose a client and assist you with determining what stage they might be at. With treatment, it's important that it is performed early. So this will rely on a quick diagnosis, and treatment will also need to be rigorous. The treatment of choice will largely depend on the stage of the deformity, and in the long term, as we move into stages 2 and in particularly 3, surgery is often required. Early on, some conservative treatments can include simple modalities such as non-steroidal anti-inflammatory drugs, or physical therapy such as rest, ice, compression, elevation, ultrasound or laser, and a really important point would be muscle strengthening. And muscle strengthening has been shown to be quite effective, particularly in the early stages of tibialis posterior tendon dysfunction. And there's a few ways you can do it. One is to use some TheraBand, which will get attached to the medial side of the foot, and the foot can invert against that resistance in a concentric contraction, and then as the TheraBand moves the foot into a pronated position, the tendon will eccentrically contract. An alternative way is to put a bag of rice on the medial side of the foot with your leg crossed, and by inverting the foot, you're pushing that bag of rice rather, towards the roof, and then you can eccentrically release the bag, and again the tibialis posterior will be contracting whilst lengthening. It's important to perform an eccentric and concentric contraction, as they're shown to both provide benefit, but eccentric is the most important one of the two. It's been shown that strengthening can improve the function and reduce the pain of clients experiencing this condition. Supportive footwear is important, as this disease will lead into potentially a very severe flat foot, and getting as much support over your footwear is critical. Hiking boots are thought to be quite a good option, as they're high top footwear and they've got a very supportive heel counter. In some instances you may even consider getting the shoes modified, or purchase shoes that have some buttressing on the medial side just to provide some extra medial support. Foot orthoses typically need to be aggressive, and Aggressive foot orthoses include those with very deep heel cups and will require an element of rear foot correction. Hence an inverted foot orthosis may be indicated, or one with a heel skive on the medial side. Foot orthoses have been shown ultimately to improve the function and again reduce the pain of clients. So along with some eccentric strengthening of the tibialis posterior muscle, it should be coupled with the use of foot orthoses. Other treatment modalities that may be considered are anything that reduces weight-bearing load on the area, such as braces and immobilization. Ankle foot orthoses can be used. Ritchie braces can as well as a cam walker, or what's another device known as an acquipush. Ultimately, all of these devices are designed to support and brace the foot and essentially immobilize the area. Steroid injections can assist with reducing pain and inflammation, but it's thought that it would require immobilization after the injection, as a steroid-induced rupture may take place, where you in fact make the condition worse. Here on the left you can see an acquipush brace. It's essentially an ankle brace that's designed to support the foot on the medial side. And on the right of screen we have a Ritchie brace, which are widely used to treat this condition, particularly in the United States. However, there are some distributors in Queensland that can manufacture these braces. Basically, the brace around the ankle is off the shelf, whereas the foot orthoses that attaches to the brace is custom made. So here we can incorporate a fairly aggressive orthotic with the ankle brace into one treatment. Surgery may be required, particularly for those who are in stage 3. Early on in the treatment, the tendon may undergo debridement and synovectomy may take place as well. Basically, the tendon is stripped back. If there is abnormal insertion present, such as an accessory navicular, correct insertion will be performed. Occasionally, the flexor digitorum longus ligament, the flexor digitorum longus tendon, or tibialis anterior tendon, can be transferred and augmented to the tibialis posterior, so they're essentially stitched together. And the calcaneonavicular, also known as a spring ligament, is often repaired. So here we have someone who has had their flexor digitorum longus augmented to the tibialis posterior tendon. So effectively, when the FDL contracts, it will now have a greater ability to supinate the foot and also resist pronation of the foot. Later on in the disease process, so getting into a serious stage 3, the talonavicular joint is often fused. The calcaneus may have a wedge removed from it, so the foot can be, or the heel can be realigned. As the forefoot abducts in stages 2 and 3, the lateral column of the foot may be lengthened so that the forefoot becomes, in line with the hindfoot and also more adducted from its original position. And or a triple arthrodesis can take place. Basically, that's where the subtalar joint and the ankle and possibly metatarsal joint are fused. Here we have someone who's undergone a lateral column lengthening process, whereby the lateral side of the foot is elongated to, as I mentioned earlier, straighten the foot up and remove some of the forefoot abduction and also reduce the valgus nature of the heel. Okay, so in summary, tibialis posterior tendon dysfunction is characterised by a weakened tibialis posterior tendon, which is typically painful and quite disabling. You need to be familiar with your anatomy in the region, where the structure originates from and where it inserts in reference to the tendon. It's important to know the 3 stages of tibialis posterior tendon dysfunction. You need to be familiar with the diagnostic signs, the clinical signs and imaging outcomes. Clinical signs, I think, are the most important. And be familiar with the treatment options. Importantly, conservative treatments which are often used and to great success, tendon strengthening and the use of foot orthoses, and in later stages of the disease, surgery may need to be considered. Thank you. I hope you've enjoyed your lecture.